Welcome to the Deakin Alumni and School of Psychology webinar with Dr. Jake Linardon. Dr. Jake Linardon is a lecturer and research fellow at Deakin University. He has published numerous peer-reviewed journal articles in the field of eating disorders and their treatment, and is particularly interested in not only understanding which psychological treatments for eating disorders are effective, but also how, for whom, and under what set of circumstances these treatments work. Thank you so much for joining us today, Jake. I'll now pass it over to you to begin your presentation.
Thanks for that lovely introduction, Lauren. And it's an honour to present this webinar today. So I'll get stuck into it straight away. So I'd just like to present an overview of what I'm going to be touching on throughout this the next 45 minutes to an hour. So I'll just talk about a brief overview of what eating disorders are and the specific eating disorder subtypes. Then I'm going to be talking about a specific form of treatment called cognitive behaviour therapy, and in particular focusing on the underlying theory, treatment, and the evidence supporting this CBT-based approach. Then I'm going to move on talking about the third wave or the third generation of cognitive behaviour therapies and looking at the current evidence base for those particular treatments. And then finally, I'm going to propose 3 directions moving forward to advance the field of eating disorder treatments, in particular focusing on mediators and mechanisms of change, looking at predictors, moderators of response, and also considering the role of technology in treating eating disorders. So just a brief overview of what eating disorders are. So we can usefully distinguish between a few different subtypes of eating disorders, and the 3 most common ones I have presented here are 1, anorexia nervosa, which is characterized by chronic restriction of food or energy intake, which usually leads to a dangerously low body weight and accompanied by various body image distortions, most typically an intense fear of weight gain. Bulimia nervosa, on the other hand, is characterized by recurrent episodes of binge eating in combination with various inappropriate compensatory behaviors. Plus, there's also a core feature of body image disturbance there as well. And finally, binge eating disorder is characterized by recurrent episodes of binge eating, but without the inappropriate compensatory behaviors. So a useful, not only does the compensatory behaviours distinguish bulimia nervosa from binge eating disorder, but usually what we see in these 2 subtypes is that people with binge eating disorder are usually overweight or obese because they don't engage in those compensatory behaviours. So why is studying these particular eating disorders, not only these, but the other ones as well, why is it important? So there are a couple of reasons. One is that they're highly prevalent conditions. So they're becoming more and more common globally across the world and of all demographic backgrounds. So what we used to kind of believe was that eating disorders affected young women of Western cultures. We know that this isn't true now. It affects women from all ages, all demographic, ethnic backgrounds, and it's also increasingly affecting men as well. So for instance, in Australia, it's estimated that more than 1 million people are diagnosed with some form of eating disorder. But we also know that there are significantly more people in Australia that have eating disorder symptoms but do not necessarily meet a diagnostic criteria. So people that binge eat irregularly, people that use unhealthy weight control behaviours and things like that. We also know that eating disorders are associated with mortality and morbidity. So, for example, anorexia nervosa has the highest mortality rate of any psychiatric disorder. That even includes depression and anxiety, and most deaths resulting from anorexia nervosa are either from suicide or the medical complications that are experienced. Bulimia nervosa and binge eating disorder as well are associated with mortality, but to a lesser extent. But they're also associated with various comorbidities like depression, anxiety, low self-esteem. And finally, eating disorders are very expensive. So the health system expenditure for eating disorders in 2012 in Australia was estimated at $100 billion. So hopefully this underscores the importance of developing effective psychological treatments for eating disorders. And in this slide is a very brief slide outlining what the more commonly used psychological treatments are and the ones that have been tested or studied in research designs. So they include cognitive behaviour therapy, which I'll touch on in a lot more detail in a second, which is essentially a treatment that helps patients or people change their unhelpful thinking patterns, behaviours, and their thoughts. Family-based therapy is typically used for younger people, so adolescents and in some cases children, and it rests on the assumption that changing things within the family environment are important for reducing eating disorder symptoms. Interpersonal psychotherapy rests on the assumption that interpersonal conflict or problems are a major contributor or cause to eating disorder symptoms. So IPT essentially helps people develop more effective interpersonal relationships or ways in which people can deal with their social settings, with the assumption that that will therefore help people reduce some core symptoms. Dialectical behaviour therapy is another common approach which views emotion dysregulation as the core problem. So things like binge eating behaviours, purging behaviours are understood to result from helping people regulate painful emotional states. So as a result, DBT teaches people a broad repertoire of skills to help replace these dysfunctional behaviours. And finally, acceptance and commitment therapy essentially attempts to help people increase their acceptance of painful emotional experiences without the need to act on those experiences, but rather living in a way that is consistent with one's values. So I'd like to primarily focus on cognitive behaviour therapy now, because, as I'll mention in a little bit, this is the treatment that has the most empirical support at the moment for eating disorders, and particularly the subtypes I mentioned earlier. So I just present this kind of schematic representation of the theory behind the treatment. So this theory essentially underpins what we do in treatment, how we treat people with eating disorders. So a couple of things to consider with this theory that we have here is that CBT is concerned with the mechanisms that are maintaining the eating disorder. So the things that are keeping the eating disorder going. This means it doesn't really, CBT is not really concerned about with what caused the eating disorder. It's more so focused on the here and now. What are the things that are keeping it going? And the idea is that if we can knock out or disrupt the things that are keeping it going, then that should have a flow-on effect to the core symptoms that we observe. And also another thing is that this theory this treatment are transdiagnostic, meaning that it can be applicable to all the eating disorder subtypes that I mentioned earlier. So CBT is a transdiagnostic approach that can treat all eating disorders that we typically observe. So as we can see in this model that I've presented here, at the core, at the very top of the diagram is what we call an over-evaluation of weight, shape, and eating. So this basically means that whereas most people without an eating disorder evaluate their self-worth on a variety of domains, so things like, their interpersonal relationships, their work performance, their sporting achievements, people with eating disorders, on the other hand, primarily evaluate their self-worth on their ability to control their weight, shape, and eating. So basically, their self-worth is equated with how they look and how much they weigh. This is problematic because what we know is that it leads to or encourages strict dieting. So strict dieting can come in many forms. So things like people fast quite often. They go for long periods of time without eating anything. So they essentially starve themselves. Or it also includes the strict dietary rules that we typically see. So the rules that dictate or govern what people eat, when people eat, and how much people eat. And we know that these rules are so difficult to sustain. So imagine trying to restrict carbohydrates from your diet for the rest of your life. That is incredibly difficult. So what the consequence of that is that those rules will generally be broken. They generally can't be sustained. And once those rules are broken, then that is assumed or hypothesized to encourage binge eating behavior. But it's important to note that there are a very small subset of cases that are successful in their dietary restraint. And that's usually the Anorexia Nervosa restricting subtype. So those people maintain those set of starvation symptoms and a dangerously low body weight, whereas most of the other eating disorder cases go on to binge eat in response to essentially that breakdown of dietary restraint, which then those binge eating, people feel really guilty about that, so they then compensate via vomiting, laxative misuse, and whatnot. And it's also important to note that there are other kind of triggers to binge eating as well. So things like sudden changes in mood. So when people feel pretty down about themselves, people then resort to comfort. comfort foods, eating because it makes them feel better very temporarily. But we know as well that that can be a bit of an issue because that just fuels the cycle as well. So essentially, this is the theory behind the treatment of CBT. So what we want to do is we want to knock out these maintaining mechanisms. So we want to knock out that over-evaluation of weight and shape. We want to target that strict dietary restraint. And we also want to help people deal better with sudden mood changes. So now I present the cognitive behavioural treatment, which is directly based on that theory that I talked about. And that image there is the manualised version of the treatment that we use as therapists. So as I said, it's a treatment that's transdiagnostic in scope. So this book here, or this manual, can be used for any eating disorder subtype. And again, it targets those factors that are keeping the eating disorder going, with little emphasis on what caused the disorder. It's a manualised treatment that lasts around 16 to 19 sessions, give or take the kind of case-by-case basis. But it's also important to note that there are self-help versions available as well. So the developers, Christopher Fairburn, he has written an abbreviated version of this book, which is a self-help book, and it's used for people that don't have access to standard treatment. And I'll talk about that in a little bit later. And the main kind of therapeutic strategies or components or modules in this book include self-monitoring. So when people record their eating behaviours, and the idea is that people who record their behaviours really get a great insight toward the nature of their problem. So what are the things that are kind of triggering or maintaining their disturbed eating patterns? There's also an induction of regular eating, where we typically instruct patients to eat 3 meals and 3 snacks a day, no more than 3 hours apart. The idea is that if we introduce a pattern of regular eating, we can knock out that dietary restraint, or more specifically, the fasting and restrictive behaviours that we usually see. We've got weekly weighing, where the therapist meets with the client once a week to weigh the client. And the idea is that the therapist helps the client interpret any fluctuations in body weight. So interpret in a more balanced view, which essentially aims to target that over-concern that I was talking about earlier. We've got exposure techniques, which helps reintroduce feared foods into one's diet. So we know that people with eating disorders usually have a list of forbidden foods that they dare not eat, because if they eat, that's a cause of anxiety and it's a real trigger food for binge eating. So the therapist here helps the client reintroduce those foods into the diet without that catastrophic consequence. Then we've also got problem solving, which helps deal with that the emotion dysregulation difficulties that we usually see. And then we've finally got cognitive restructuring, which is a broad collection of techniques that help clients essentially change or modify the way that they think about their body and about eating. So what's the evidence for CBT at the moment? So first up, essentially, this type of treatment approach is the front-running treatment for binge eating disorder subtypes. So disorders of binge eating like bulimia nervosa, binge eating disorder, and your other specified feeding and eating disorders. And clinical guidelines all over the world recommend CBT as the first step in treatment. So that's what we should be giving to people with eating disorders as a first step. That's what the recommendation is. And that's based off a series of meta-analyses and systematic reviews that have been published. I've been lucky enough to publish quite a few meta-analyses on CBT within the past couple of years. And here are the findings from the meta-analyses that I've led on the effectiveness of CBT. So one, we know that CBT outperforms pharmacotherapy, so typically antidepressant medications, as well as specific other evidence-based psychotherapies, so things like interpersonal psychotherapy and even non-directive supportive counselling. So CBT is better than those other treatment approaches. We know that CBT is most effective when it's based entirely off that transdiagnostic book that I talked about. So there are other different CBT protocols or approaches that are available as well that are based on slightly different theories and slightly different techniques. But we've observed that the effects are strongest when it's based on that book that I presented earlier and that model that I presented earlier. For bulimia nervosa, we know that 43% of people who receive CBT completely stop binge eating and purging. So it's only 43%, and I'm going to touch on a little bit more about that in a couple of slides to come. For binge eating disorder, it's a little bit better. So we observe 58% are expected to completely abstain from binge eating. Remember that binge eating disorder is not characterized by purging. So we can stop, in 58% of the cases, we can completely stop binge eating. And importantly, I think another important thing to demonstrate is that there are broader effects of CBT than merely symptom reduction. So we've published a couple of meta-analyses showing that CBT has a very positive impact on quality of life. So people's well-being and their quality of life significantly improve after they receive CBT, independent of their reduction of symptoms. And we also know that depression is very symptomatic of eating disorders. It co-occurs with eating disorders to a great extent. And we've shown that delivering CBT also has a very positive impact on reducing any co-occurring depressive symptoms in people with bulimia nervosa and binge eating disorder. So what does this mean? So what are the implications of this? I think the biggest implication of this is that given that CBT outperforms other specific psychological treatments, it's kind of suggesting that it's likely that it isn't the factors that are common across all psychological treatments that are making CBT work. So things like the therapeutic alliance, showing empathic concern. It's more so likely that what makes CBT effective is the specific ingredients that underpin CBT. So those techniques that I was talking about earlier. That's not to say that the therapeutic alliance and other common factors are not important. It just means that they're necessary, but they're not sufficient in order to produce the best kind of outcomes. So that was the evidence for CBT, and that CBT that I was talking about there is typically referred to as the second wave of CBT. So now I want to talk and move towards the third wave of the CBT approaches, which is gaining heaps and heaps of momentum and attention and kind of research attention as well. So CBT, as I talked about, it's not a panacea. It doesn't work for everyone. And what we know is that a lot of people stop CBT. They don't like it. They drop out. They discontinue. So it's estimated that around 25% of people, so a quarter of people who receive CBT, drop out early. We also know that some people who receive TBT do not respond at all. So they show no improvements. And in some cases, they actually get worse. And then finally, we know that people who improve or recover, it's very common for them to go on to relapse later on down at follow-up periods as well. So it's not the best. It's not the be-all and end-all. More progress needs to be done. So it's been suggested that, one, we need a broader range of effective eating disorder treatments. So we need more kind of options to help people with. And the third wave cognitive behavior therapies are touted as a possible solution to this. So what are they? So the principles and the techniques of these third wave cognitive behavior therapies are quite different to the second wave approaches that I was talking about. For instance, rather than trying to change the content or the validity of cognitive or emotional processes, as is documented in the second wave, as is mentioned in the second wave approaches, the third wave treatments aim to target the function or the awareness of these cognitive or emotional processes. So really trying to change the relationship someone has with their cognitions and their emotions. So in saying that, the third wave approaches primarily use response-focused emotion and cognitive regulation strategies, which are essentially strategies that help people deal with their responses after the cognition or the emotion has occurred. That's a little bit different to the second wave approach that I talked about earlier, which tries to prevent those emotions and cognitions from occurring in the first place. The third wave is a little bit different. It allows them to happen, but it's what we do after it that is the key difference there. So common techniques used in these third wave CBTs are acceptance, mindfulness, metacognition, and psychological flexibility. So I was quite interested in the third wave of the cognitive behavior therapies and looking at what we know about them in the context of eating disorders. So we published a systematic review shown in this slide here in quite a prestigious journal, looking at the empirical status of all of the different third wave therapies. And what we just essentially wanted to do was just look at the current evidence base for them across each eating disorder subtype. And what our primary aim of this paper was to determine whether or not each third wave treatments are considered empirically supported. So we used some established APA criteria for determining whether or not the treatment was an empirically supported one for each eating disorder. So we can usefully distinguish between a couple of different types of empirically supported treatments. One is that it's an empirically supported treatment that is specific in its mechanisms. So all that means is that a treatment outperforms a pill or another evidence-based treatment in multiple randomized control trials by many different research groups. The second criteria is that it's an empirically supported treatment, full stop. So that essentially means that the treatment outperforms no treatment in multiple randomized control trials conducted by more than one research group. So the more than one research group is a really important point to consider, because we need independent groups to replicate our findings. Because if multiple studies show that one treatment works, but the researchers have a really strong allegiance to a particular treatment, then it's probably not the best representation that we have, because people that have a strong allegiance to a particular treatment expect their treatment to work. So we need people to replicate these findings that don't have such a strong allegiance to their treatment, because it's a more kind of balanced appraisal of the evidence for a particular type. And then we can also talk about a possible empirically supported treatment. So that essentially means that a particular therapy is better than nothing or better than no treatment in one study or by more than one study by the same research group. So that's just the criteria we use. I'm just providing a bit of background to the criteria that we use to determine whether each third wave therapy was empirically supported or not. So this brings us to the findings of this particular paper that I talked about. So in this paper, we identified 27 studies that looked at the effects of a particular third wave treatment. And the third wave treatment is listed on that table there. Only 13 of these were randomized control trials. And we need randomized control trials because they allow us to determine a cause and effect relationship. So what we found was it was quite promising in that each of the treatments that are listed there produced very large improvements in symptoms. So that effect size I presented there is a G of 0.8. That essentially means that there were quite big improvements in symptoms. However, there's a caveat to this in that they were based on uncontrolled studies. So it's impossible to determine whether improvements were a result or were caused by a treatment or were kind of caused by other naturally occurring factors. So whether or not people just got better over time, or regression to the mean or things like that. So essentially all I'm trying to say is that findings based on uncontrolled studies cannot tell us whether or not it was the treatment that produced that improvement. So what we wanted to do was then look specifically at the randomized control trials that allow us to determine that cause and effect relationship. And we wanted to just simply state whether or not each of the third wave treatments were empirically supported. And in this table here, we've got kind of what we found. And this is a similar table that we've got in the paper. So for anorexia nervosa, the outlook is pretty dire in that none of the third wave therapies are empirically supported at all. And that's largely because these treatments haven't been tested yet in RCTs. The only exception is there's been one trial to my knowledge of acceptance and commitment therapy, and unfortunately ACT didn't even outperform a waitlist control in that study. So it was no better than receiving nothing, which is quite surprising actually. So there's no empirically supported treatments for anorexia nervosa. It's a little bit different for the other two disorders, so bulimia nervosa and binge eating disorder, is that in that we have a few that are possibly empirically supported treatments. And that's because they're possibly empirically supported. It's because that's only one RCT has been done on them. And it's been showing quite a bit of promise in that all of those treatments have outperformed no treatment, but we need more research to kind of demonstrate that they are empirically supported. So essentially what we concluded in this paper was that CBT, or the second wave CBT, needs to retain its status as the treatment of choice for these particular eating disorders. And at the moment, these third wave treatments can only be considered experimental until much more research needs to be done to kind of look at their evidence base. So it's quite tentative at the moment. So what have we got so far as a summary of the treatment? So I think it's important to note that over the past 20 years, that huge progress has been made in developing these kind of treatment approaches and showing that they have a lot of promise, that they're helping a lot of people. But there are still a lot of issues that still remain across the literature. And one is that a huge number of people do not fully respond to even our best available treatments. So earlier I said that that more than half of people with bulimia nervosa that receive CBT do not fully recover. That's not to say that they don't improve a little bit, but they don't fully recover or they don't fully respond. Also, we're not able to kind of determine who is and who is not going to benefit. And I'll talk about why that's a problem in a second. Third, we have very little understanding towards how, why, and through what mechanisms a particular treatment works. So really understanding that, okay, what is it about the treatment that's making it work? Why is it doing it this way? Again, we have very little understanding of that. And again, I'm going to talk about why that's a problem in a second. Fourth is that I briefly mentioned earlier that there's quite a lot of people that just drop out from treatment early. And we know that people who drop out are likely to fare much worse than people who complete a treatment. So people who drop out are still likely to be very symptomatic over the course of their life compared to if people remain in treatment. So we need to kind of understand ways in which we can prevent dropout, minimize dropout, or anything that kind of, minimizes or prevents dropout. And we've published a meta-analysis looking at estimating the prevalence of dropout from CBT. And we've found that 25% of the people with eating disorders tend to drop out early from treatment. And these are the ones that really do poorly later on in life. So we need some strategies to kind of overcome this. And I think probably the biggest issue that we're facing at the moment across the literature is that fewer than 25% of people in need of help actually receive treatment. So that's 75% with an eating disorder or symptoms that are close to meeting criteria for an eating disorder either don't seek treatment or they can't access it at all in some way. And I'm going to talk in a little bit about the reasons as to why that's happening and how we can potentially overcome that. So overall, what it says is that, yes, we've made a lot of progress, but there's still heaps more to be done to essentially improve this population group. And what I think, based on kind of my work in this area at the moment, I think that there are three very important future directions that can kind of help this go forward to some extent. I'm going to talk about each of these future directions now. And the first one is we need to identify the mediators of change. So what that means, so what a mediator is in the context of psychological treatments, they're essentially variables that explain how, why, or through what mechanisms a particular treatment works. So as I talked about earlier, at the moment, we know that CBT works for some people. We know that it's effective, for around half the people that receive it. But a crucial point to note is that we don't know how it works or what components of CBT are responsible for making it work. So for instance, is it that regular eating strategy that I talked about earlier? Is that the thing that's driving the reduction in symptoms? Or is it the weekly weighing strategy that I talked about? Or is it the problem solving, the self-monitoring strategy? The issue is that we don't know this. And it's because when we test these particular treatments, we test them as a package. We test them all combined into one package and we deliver that package to a sample of people with eating disorders. And that if we document that it's effective relative to no treatment or another treatment, we just assume that all of these components are effective. But that's not the case. It's likely that some are effective and that some aren't. So that's where mediators come into it. They tell us specifically what those active ingredients are, what those components are that are making people get better. And also, what are those components that are not making people get better at all? So what are those redundant components? But then the issue is, so who cares? Like, why do we need to know what the components if it's working, why do we need to worry about that? Well, there's a few reasons for this. So if we know what components or aspects of a particular treatment are effective, then there are a couple things that we can kind of ensure. And one is that we can really emphasize them in treatment. So we can spread the word to all clinicians around the world delivering CBT and say, hey, you need to make sure you really emphasize this particular component in your treatment in order for maximal outcome. So we can kind of anticipate that people will have a better outcome if they're emphasizing that particular component of treatment. The second one is that if we know which components of treatment are effective, then we can develop and even refine those components to make them even more powerful than what they already are. Because we know we've got a starting point, then we can expand on them and make them even more potent, and as a result, improve people even more so. And third, if we know what components aren't effective, so what are the mediators that aren't actually working, then we can just remove them from the treatment. We can get rid of them because they're not doing anything. And the benefit of that is it's going to use up less resources, because it would mean that we need less sessions with a therapist, and as a result, we can make treatment more efficient, more cost effective, and essentially save people's time and money without giving them something that isn't going to work for them in the first place. So theoretically, if we take that all together, it means that if we understand what the mediators or mechanisms of change are, then treatment would theoretically be more effective, more efficient, and at a lower cost. The second important future direction, I think, is looking at predictors or moderators of response. So when I'm talking about predictors, I'm simply talking about variables that correlate with an outcome or improvements, regardless of the type of treatment delivered. That's a little bit different to a moderator, which is a variable that interacts with treatment to predict an outcome. So in other words, it's a variable that correlates with an outcome only for a specific treatment, but it doesn't work for another treatment. It doesn't correlate with outcome for another treatment. And I'll go through an example in a second of what I actually mean. So these types of variables, predictors and moderators, are very important for kind of understanding who is and who is not going to respond to a particular type of treatment. And we published a systematic review a few years ago looking at the evidence base for predictors and moderators of response. And we found the same conclusion, is that we have no idea yet who is likely going to benefit from treatment. So it's almost like clinicians are going in with a blind eye and have no idea whether or not they can anticipate this client will get better or this client will not get better, which is a big problem. And I'll talk about why that's a problem in 1 second. So why do we need to bother studying predictors or moderators? And hopefully it will make sense. So there are two main reasons why we need to study them and why it's important. The first one is that it's important for treatment matching. And what I mean is, we can decide, if we know what a moderator variable is, we can decide what type of treatment a patient will receive based on their demographic or their clinical profile. So if I use a typical example, let's just say that we've identified that low self-esteem, so people with low self-esteem to begin with, do very poorly with CBT, but they actually do quite well with IPT. So that's what we call moderator. Self-esteem in that case is a moderator. So if we know that self-esteem is a moderator, then what a clinician could do is, if they get a new case with an eating disorder and they're trying to decide what treatment there is, if they kind of gauge their levels of self-esteem and they identify that this particular person that they're dealing with at the moment has a very negative view of themselves, it would not make any sense at all to give them CBT, because that is likely going to determine that they're going to have a poor outcome. Therefore, the clinician might decide that IPT would be the best approach for that particular person. So that's what we call treatment matching. We're matching a particular treatment to a person based on their kind of profile. And we can also tailor interventions as well based on predictors. So for instance, if we identify that at age as a variable that correlates with outcome, regardless of the type of treatment a person receives. So let's just say younger people do worse than older people in eating disorder treatment. So in that case, age is a predictor of outcome. So what we could do then is that if we know this, we might be able to tailor our interventions accordingly. So if a clinician comes in to treat someone with an eating disorder and they're of younger age, and we know through evidence that younger people do worse than older people, well, what can we do about that? Well, there are a couple of things we can do about that. We can tailor our intervention in a couple of ways. One, we might be more intensive. So we might say to the younger person, hey, I want you to come in 2 times a week instead of that 1 time a week. I want to be able to monitor you a little bit more. Or alternatively, you could provide more frequent and longer sessions to the younger person. So all I'm trying to say is that there are a bunch of ways in which we might be able to beat the trend, essentially, and try to prevent younger people from having a poorer outcome by just giving them more support. So ultimately, those 2 things, treatment matching and tailored interventions, will stem from if we identify predictors and moderators. And the big kind of outcome of this is that people will get better. The improvements in outcomes will occur theoretically if this happens. So it should be a very important priority for future work. And the final future direction that I think is very important is to capitalize on technology. And the reason for this is that we know there's been some research that's been done to show that less than a quarter of the people who are suffering from an eating disorder have access to or seek treatment. And there are many, many reasons as to why this happens. So the big pool of people, the 75% of people who are still suffering by themselves without any help at all, the reasons for why this is occurring is that, one, there's too few trained therapists out there. So there aren't enough therapists to accommodate the massive pool of people that are suffering from an eating disorder. And there's even been some work done showing that even tripling the number of trained therapists worldwide will have essentially no impact on this. So what are we going to do about that? And I'll talk about that just in a second. The second reason is that it's too expensive treatment. So at the moment in Australia, Medicare covers us 10 sessions of psychological treatments. And as I talked about, for CBT to work at the moment, we need about 16 to 20 sessions. So Medicare covers half of that. It just doesn't really make sense. So it's too expensive for people to kind of afford. The third one is that there are huge geographical constraints. So particularly people living in really rural areas cannot access treatment. There's no treatment center available to them at all. So how are they going to be able to access these evidence-based treatments? And the final reason why people don't get treatment is because of the stigma associated with mental illness. So many people with eating disorders, not only eating disorders, but other things like depression, anxiety, they're ashamed of their condition. They don't want to speak out about it because they're embarrassed of it. So what we need to do is we need to kind of overcome these barriers. We need to find ways in which we can reduce this huge gap we're observing in the treatment sphere. And one very, very important way to reduce this huge gap is by capitalizing on technology. So capitalizing on the internet, using smartphones. And why is that? We know that most people around the world have access to a smartphone, have access to a computer, an internet, and things like that. So what we can do is we can translate the components of evidence-based treatments from that manual that I was talking about and try to embed them within the internet, the computer, or a smartphone. So people have something that they can use by themselves. And if we can do that, then it will reach an enormous amount of people for little to no cost at all. So it just may be that this low intensity intervention of smartphones will do the trick. It may help some people. It might not be beneficial for other people, but if it helps more people than otherwise would if we didn't give these smartphones, then I think that's a win. And what we can do is use a particular stepped care approach, which is that everyone who has a particular condition start off with this minimal intensity intervention. So download an app that helps them with their eating disorder, use an internet-based treatment. But if they don't respond, then they may go on to the more kind of intensive psychological treatment. So we're kind of saving the resources for the people who are more severe. And there's good evidence showing that it's a very promising approach for other disorders like depression, anxiety, even stress and things like that. So it's showing a lot of promise, but in the field of eating disorders, essentially very little is known. There's a couple of trials that's looked at computerized treatments for eating disorders, and that it's showing promise. It's showing that people are benefiting from it. But in terms of smartphones and apps, there's essentially no trials being done on that. So that's where kind of I think I'm hoping to step in terms of really capitalizing on technology and trying to translate the CBT based on that approach towards an app so that people worldwide can have access to some form of care and essentially improve the quality of their life and reduce their symptoms. So they're the three, in my opinion, they're the three important future directions that are needed to advance the field of eating disorder treatment and to essentially help many more people, billions and billions of people worldwide, get access to some sort of care. And that's where I end off. Thank you very much for that, for listening to my presentation. And I'll pass it on to Lauren now.
Thanks so much for that presentation, Jake. It was really, really insightful, and we did go through a lot in 45 minutes. So listeners, it's now time for our Q&A session. So if you have any questions at all, please feel free to type them into the question box. We have a listener who's wondering what the name of the book was that you mentioned.
Yep. So it's the name of the book is just called Cognitive Behavioral Therapy and Eating Disorders, and it's by Christopher Fairbairn. So you can buy that book online. It's more of a clinician book, so it's primarily used for clinicians for their patients. But what I would recommend if anyone was interested in kind of implementing these strategies by themselves, there is actually self-help books out that are based on that approach. So the same author has written an abbreviated version of that book. And the idea is that people can use the steps by themselves. And that book is called Overcoming Binge Eating. It's essentially the same thing as that other book that I showed you in that slide. It's just a shorter version. It's got the same techniques and principles. But it's called, Overcoming Binge Eating by Christopher Fairbairn, and you can buy that also online, or I think it even might be in the shops. But I highly recommend it. It's such an easy-to-read book, and it's got great steps to follow.
We have another question is, what are the current recommendations for treatment of anorexia nervosa?
Yeah, so anorexia nervosa is a little bit tricky. To be honest, it's not so much my area of expertise. I focus more on bulimia nervosa and binge eating disorder. But what we do know in anorexia nervosa is that family-based treatment, particularly for younger, populations, is generally the recommended treatment approach for younger people with anorexia nervosa. And there's also a treatment approach that is also based on family-based principles called the Maudsley Approach, and it was developed in the UK. And that's also been shown to be quite effective for people with anorexia nervosa of all ages. But the issue is that with anorexia nervosa, we haven't yet to determine what the most superior treatment is. So when we've compared many different treatment approaches to anorexia nervosa, we typically find that both produce equivalent effects. So as a result, we don't know what the best one is just yet. There are some recommendations that CBT and family therapy are the way to go. They should be your first kind of line of treatment. But we've got but we're just a bit unclear of what's the most superior one. It's a little bit different to bulimia and binge eating disorder, where CBT is a clear favorite at the moment. So it's clearly the most effective one. Good question.
And Julia asked, what are the current recommendations for treatment of anorexia? Oh, no, sorry. I already read that one out. Yeah. Sorry. Nicole asked, wondering if there is any research about the efficacy of 12-step models in this area.
To be honest, because I've done a lot of systematic reviews on psychological treatments for eating disorders, and I haven't come across any of the 12-step models for eating disorders. My understanding is the 12-step is kind of taking an addiction-based approach. There is some work on food addiction, but there certainly hasn't been any leeway into conducting studies on the 12-step approaches in people with eating disorders. I guess it could be a future direction given that the increased interest in food addiction, but yeah, at the moment it would only be theoretical. So we don't know just yet.
Question from Sandra is, thinking of the use of technology, how much supervision monitoring would be required to evaluate the outcome, and who would be responsible for it?
That is an excellent question. So we've just actually published a meta-analysis on technology-based interventions for mental health problems. So not just eating disorders. We looked at everything: depression, anxiety, stress. And what we consistently found was that any degree of supervision was beneficial. So what we found, that any degree, whether that be, a clinician was just sending encouraging text messages, whether they were calling them just to check in how they're going, they need any help, anything like that produces much better outcomes compared to if people are left alone to do them. But the dose, or the exact or precise amount of support needed, is a bit unclear. We're not sure what the optimal dose is for the optimal dose of, support needed is at the moment. I guess it's a really important thing to think about in the future. But what we do know at the moment is that is something is better than nothing. The next step is to then talk about, okay, then what is that something? How much of that something is needed? Good question.
Brenda has asked, would any of these techniques and principles be useful for addressing obesity?
Absolutely. So we usually see that binge eating disorder is highly comorbid with obesity. The reason, as I mentioned earlier, is that it's because people with binge eating disorder eat a lot of food, but they don't compensate for it like anorexia nervosa. So as a result, obesity is quite common. And the same principles can be applied. So we know that people with obesity, generally speaking, have a relatively negative view of their bodies. So a lot of the body image components can be applicable to them. But what if we want to help people control their consistent overeating, or grazing or binge eating, we can also use the same approaches too. So we can also use that regular eating that I was talking about. So really making sure that people eat regular intervals, because what we see a lot with people with obesity is that they may go for quite a bit of periods without eating, and then they'll just succumb to the temptation of, or the kind of the deprivation of not eating for a while, and then that's when kind of all hell breaks loose, and then they go on to binge eat. So we can definitely use the same principles for people with obesity, and it's been shown to be quite effective in this group as well.
We have a question from Peter asking if any other AN treatments with established efficacy for adults.
Yeah, so as I mentioned a bit earlier, as I talked about, CBT is one of them, and probably the other one is the Maudsley Approach to treatment, which is based on kind of family-based principles too. And there's also another one called Specialist Supportive Clinical Management. So that's just basically getting in a multidisciplinary team consisting of psychiatrists, nutritionists, GPs, and really kind of taking it on a case-by-case basis of what can actually be done. There's actually a manual published on specialist supportive clinical management. And interestingly, this type of approach has been shown to be equally effective to CBT and the Maudsley approach as well. So that's another way in which we can treat them. Again, there's no clear standout to what treatment is the best, but we know that we have a few options available. That's why we need to look at moderators. So what particular person will benefit from what particular treatment?
Another question from our listeners is comorbidity a factor that impacts outcome in CBT for eating disorders?
Yeah, that's also a great question. So we did a review paper in 2017 that looked at all of the variables that have been studied as predictors of outcome. So that's kind of the same thing as impacting outcome. And we looked at a bunch of different comorbidities. So like depression, anxiety, substance abuse, all of the mental health, other co-occurring mental health conditions that have been looked at as determinants of outcome. And what we found is that there's no available evidence to suggest that those things have a detrimental impact on outcome, which is good because it means that we can go in not worrying too much about those other signs and symptoms and just really focus on the eating disorder as well. It's not to say we shouldn't pay attention to them, we should, but we can be confident at the moment that they're not going to be too detrimental to a person's outcomes later on.
Rayleigh asked, twin studies, identical twins with anorexia nervosa, recovery outcomes if ED commenced at an early age, 8 to 10 years old, and is still and is still current at age 19 to 20 years?
I'm not entirely sure of the question, but I wouldn't be capable of answering that question because I don't have any expertise or knowledge in twin studies. I'm sorry about that.
Stephanie asked, would you work in conjunction with a dietitian for any of these?
Absolutely. Yes, you certainly would. I think in the manual in CBT usually recommends a team approach that consists of a therapist who's working in conjunction with GPs, dietitians, and things like that. So that just forms part of the components of treatment that we need to make sure that we're doing for those. And that is the same with all the other treatments that I talked about earlier. So yes, they're certainly a very important aspect to the treatment team.
And we might leave this as the last question. What's the current evidence for self-help treatments?
So that's a good question. So the self-help treatments are the Overcoming Binge Eating book that I spoke about a little bit earlier. So the self-help, so we know that guided self-help is when, someone is helping someone along the guided program. So whether that be a clinician, whether that be it could even be a research assistant, we know that produces quite important outcomes in terms of that it works. But the thing is, it only works for people with binge eating disorder. At the moment, there's no evidence to suggest that self-help is effective for bulimia nervosa. There've been a couple of trials on it documenting that it's not even better than simple waitlist controls. But for binge eating disorder, it is quite good. It's the kind of first step in treatment that's recommended. And the reasons aren't entirely clear, but we've shown in our work that binge eating disorder is easier to treat than bulimia nervosa, and it would be another webinar in and of itself to explain why that would be the case. So I probably won't go into the details there.
Thank you all so much for listening into today's presentation with Dr. Jake Linardon. If you have any follow-up questions, please feel free to contact him directly. His details are on the screen. And thank you so much for your time today, Jake. Thank you to our listeners for tuning in and participating in today's webinar. We hope you can join us again next time.
Thank you.